Hello, this is Dr. Weaver, and today we're going to talk about diagnostic imaging in preparation for taking the VTNE. Our test tip of the week is to use guided imagery to help you perform better. So professional athletes will use guided imagery or some sort of mental rehearsal before a big game or before a big performance in order to enhance their performance. And we can do the same thing. So imagine the day of your test. Visualize yourself sitting in front of the computer in the testing center. You feel calm, your mind is clear, your mind is focused. You read questions, you jot down notes, and you get the correct answers. Putting yourself through this guided imagery situation can help you perform better on the day of your exam. I've also included a link that shows what a PSI testing center looks like, so you know what the experience will look like, and it'll help you with your guided imagery. So click the link and watch the PSI testing center video. Today we're going to cover how x-rays are created. We're going to talk about how to adjust the technique if our film doesn't look very good. We're going to review the inverse square law. We're going to talk about scatter, talk about distortion, magnification, directional terminology for the equine limb, fluoroscopy, and ultrasound. All right, so as a review, x-rays are made inside the x-ray tube. This could be referred to as focal. So sometimes we're talking about the focal film distance. We're talking about the x-ray tube where the x-rays are produced. It all starts at the cathode, which is negatively charged, and the cathode produces electrons by a tungsten filament. When the exposure switch is pressed, the electrons go zooming across the x-ray tube towards the positively charged anode, and the acceleration of these electrons is controlled by the kVp. Now, I always have a hard time remembering what direction these electrons travel. And so I think about being a student, and if I have a C- in the class, I want to go to an A+. But I don't want to go from an A+ to a C-. No. That's not the direction I want to move. So I want to move from a C- to an A+. Electrons travel from the negatively charged cathode, C-, to the positively charged anode, A+. The anode has a beveled tungsten metal target, and beveled means it's at this angle. When we engage the prep switch on our pedal, we start the anode rotating. And so often you can hear this whir, and that's the anode warming up and starting to rotate before the exposure switch is activated. Electrons are released from the cathode, they go zipping across to the anode, and they strike this tungsten metal target. 1% of the electrons are turned into x-rays. The other 99% are just turned into heat, so it gets pretty hot in there. The beveled surface has a focal spot, and that focal spot directs the x-rays downward through a housing window. And the smaller the focal spot, the sharper the image will be. Now, the anode can have this heel effect because it restricts the number of x-rays exiting the tube on the anode side. And if I think of the bevel, it's kind of shooting the x-rays out at an angle. And so the anode side doesn't get as many x-rays leaving the x-ray tube. And so when we're taking images, we want to be sure we put the thickest part of the patient towards the cathode to take advantage of this anode heel effect. And when you look at your x-ray machine, you can see which side is positive anode and negatively charged cathode. On our machine, the cathode is towards the left, and so we always put the thickest part of the patient towards the left as you're facing the machine. The aluminum filter removes low energy or useless x-rays before they leave the tube. So this aluminum filter is inside that x-ray tube head, and it removes the low energy or useless x-rays. We also can collimate the x-rays that are leaving, and this will limit radiation exposure, decrease scatter, and improve the quality of our image. So we're always trying to collimate as tight as possible so that we're including the structures of interest, but we want to minimize how much extra area is in the primary beam. Remember, scatter radiation is released in random directions. It's the x-rays that bounce off of our patient or bounce off of the table, and so they get projected outwards in all sorts of different directions. And these are the highest exposure hazard to the patient and the technician. As a technician, we should never be in the primary beam. So the beam that comes straight down from the x-ray tube to hit the patient, that part we're not supposed to be in the primary beam at all. But when we're in the room holding a patient, we get exposed to the scatter. Things that cause more scatter are larger patients. So it's like the larger the size of the patient, we're using higher settings, and the x-ray bounces off more. Poor collimation leads to more scatter, and higher KVP settings lead to more scatter. Now, we don't want the scatter to mess with our image. We want to take a really high quality x-ray picture, and the scatter can sometimes bounce around and affect what our image looks like as well. So the solution is that we have this grid, and usually the grid is underneath the table, but between the cassette or the receiver, and it reduces the scatter from hitting the film. And these are used even when we have a digital receiver. We still have a grid to reduce the scatter. And the grid is kind of like Venetian blinds, so it only allows the x-rays that are coming straight through to pass. Anything that's scatter and like bouncing around at funny angles gets absorbed by the lead strips in the grid. We can avoid a grid for extremities that are less than 10 centimeters. And in this case, they can be x-rayed on a tabletop cassette. And even with some digital processors, you can move your digital receiver onto the table, avoid the grid, and take an x-ray of the extremity on the tabletop. So in this picture here, a woman is getting an x-ray of her arm. The film is on the table instead of being under the table below the grid. So you need to remember that anytime we have something that is greater than 10 centimeters, we need to use a grid, and the film should be under the table. But for extremities or animals that are less than 10 centimeters, we can use a tabletop view. We don't have to, but we can. Here's a picture of a grid, and I talked about the Venetian blinds. A lot of people have these in their house, and so you can rotate your blinds in different directions, and they only allow light to pass through in one direction. The grid is designed to do the same. It only allows the primary x-rays to pass through and expose the film. All of the scatter gets absorbed by these lead strips, and it doesn't affect the quality of our image. Okay, so next we have some settings that we need to review, and you need to be really comfortable with these two settings for the VTNE. There's going to be questions on these different settings. First of all is the KVP. KVP is the power, the quality, or the penetrating power of the x-ray beam. And I think of someone throwing the ball, and the KVP is the strength that they throw that ball at. The KVP impacts both the density and the contrast of our image. Remember, the density is how dark or light it appears, and the contrast is how well we can tell the difference between shades of gray. The MA is the quantity of beams, and I think of this being a whole bunch of tennis balls being thrown. So how many tennis balls or how many x-rays are thrown is set or determined by the MA. And this, adjusting your MA, impacts just the density, so it impacts how dark or how light something is. So here's a review of density. Density is the overall lightness or darkness of an image. It's determined by both the quantity and the strength of our x-rays. And we see an increased density as the x-ray source gets closer to the film. So density is influenced by our settings, KVP and MA, and also by the focal film distance. Remember when I was talking about the x-ray source or the tube, I called it a focal. That's just a fancy way of saying the x-ray tube head. As it gets closer to the film, the image will appear darker. Now we also have some words that we use in describing density. So if an image is really dark, we say that it's overexposed. And I think of this like burnt toast. If I've overcooked my burnt toast, it's going to appear darker and darker. So overexposed is too dark. Underexposed means I haven't cooked my toast enough and it's too light. So an image that is overall too light is underexposed and has not enough density. And an image that is too dark is overexposed and has too much density. Okay, do you understand how those words are used together? Be sure you're comfortable with this terminology because it'll really help you understand the questions and the answers when you're taking the VTNE. Now, another image quality is the contrast. And this is the degree of difference between our different materials. So remember sometimes we call them our densities in the body, but our different organs have different appearances on X-ray, and air appears black, fat is a darker gray, water or soft tissue density is a light gray, and then bone appears white. So those are 4 naturally occurring densities in the body, and they have different appearances on X-ray. Now we want to be able to see the difference between them. So if my air looks the same as my bone, I have very poor contrast. I need them to appear different because they're very different materials, they're very different substances. And the setting of the KVP affects the contrast between our different body parts. So KVP affects contrast. I'm going to say it again in a different way. So the KVP is the penetrating power behind the X-ray. And I want you to really take note. If you see penetrating power or anything about penetration, we're talking about KVP. Those two are synonyms. You can substitute one for the other. The MA, or the milliamperage, is the quantity of X-rays produced. Now the other setting that we can affect is the seconds. This is the time of the exposure. So how long are we sending these X-rays from the cathode to the anode? Like how long is the exposure occurring? And basically a longer exposure time leads to more movement artifact. If we have a wiggly patient and we have our exposure set for a long time, they're going to wiggle during that exposure, and that leads to a really blurry X-ray. I bet you can all imagine taking a picture when the light is low and there's movement, and the image appears really blurry. So we get movement artifact if our time is longer. So a longer exposure time leads to movement artifact. Longer exposure times can also lead to more radiation exposure. And then the MA is multiplied by the time in seconds to get the MAS. And so in this example before, we have 300 is our MA. Our time is 1/30th of a second. So our MAS is 10. And this is something you need to be able to do. So you need to be able to multiply your MA by your time to get an MAS. So in this example here, we have 2 different situations. We have an MA of 300, a time of 1/30th of a second, which equals an MAS of 10. And then in the second option, we have an MA of 100, a time of 1/10th of a second, and the MAS is 10. So which of these will have less chance of movement artifact? Answer in your head. Hopefully you got the 1/30th of a second. This is a much smaller time. If we divide a pizza into 30 slices, each slice is smaller than if we divided it into 10 slices. So remember, when we're looking at time as a fraction that has a bigger denominator is actually a smaller slice of time. I know this is kind of tricky for students, but practice it a little bit and hopefully you get the hang of it. So sometimes we're asked to adjust the exposure factors if our first image doesn't look the way we want it to. So if our first image is too dark or overexposed, we can fix that in 2 ways. We can either decrease the KVP by 10 to 15%, or we can decrease the MAS by 30 to 50%. Remember, both of those impact density. KVP changes are always 10 to 15%, and MA changes are always 30 to 50%. So the percent change goes with the setting that it refers to. If our image is too light or it's underexposed, we can either increase our KVP by 10 to 15% or increase our MAS by 30 to 50%. And so sometimes we have to pick which one. And how do you decide which one to fix? Well, usually questions will cue you in to which one is the problem. So remember, we're looking for words about penetration or contrast. Those talk about KVP. So let's practice and maybe you'll understand what I mean. Here's an example. If a radiograph is too light and the image appears underpenetrated, you should... Okay, remember the hint is that penetration equals KVP. Let's read it again, substituting KVP for penetration. If a radiograph is too light and the image appears under KVP'd, you should A, increase the MAS, B, decrease the KVP, C, decrease the MAS, or D, increase the KVP. Okay, I know I need to increase my settings. My picture is too light. My toast isn't cooked enough. And I know that it's a KVP problem because it's under KVP'd. So it's the KVP that I need to correct. I'm going to increase the KVP by 10 to 15%. Here's another one. If a radiograph is too dark, but the image shows adequate penetration, you should. And remember, we're going to substitute the word KVP for penetration to help solve this. Let's read it again. If a radiograph is too dark, but the image shows adequate KVP, you should A, increase the MA, B, decrease the KVP, C, decrease the MA, and D, increase the KVP. So the first thing I think is, okay, my toast is overcooked. I need to decrease my settings, right? I've got burnt toast. My picture is overexposed. I've got to decrease settings. So I'm looking at B or C. And the STEM or the question said that my penetration, my KVP was adequate. So that was the clue that the answer is to decrease the MA. The question itself said, this isn't a KVP problem. So that's how I know that I need to decrease the MA by 30 to 50%, and that's the correct answer. The inverse square law, I think this makes sense to people intuitively, but the terminology gets so muddy. As you move further away from a source of X-rays, you are exponentially safer. So if I am 10 feet away, I am exponentially safer than if I was just 5 feet away from the X-ray source. The intensity of the X-ray beam, or the MA, is inversely related to the square of the source image distance. So when I say something is exponentially safer, I'm talking about it is squared. So that square is the exponent that we're referring to. And let's practice, which might help this be clearer. If an operator can increase the distance from the primary beam by a factor of 2, what would the resultant dose of radiation be? So, in this situation, I am a distance of 2 further, but my intensity is 1 over 2 squared, or 1/4 less radiation. So if I increase my distance away from the X-ray source by a factor of 2, my intensity is 1/4 that of what it would have been before. Penumbra refers to blurry edges, and basically a smaller focal spot will lead to a sharper image, although the anode could overheat with a smaller focal spot. If we have a really large focal spot, the anode will stay cooler, but the image margins will get blurry. I also see this with collimation. So if I am collimating for a really large dog or cat, the edges of the image might appear blurry. Whereas if I am collimating in a much smaller area, the entire image appears sharper. But this has to do with the focal spot. Now we can see distortion of a structure based on the angle that our bone is at. So let's use bone as an example. Say I want to take an x-ray of the radius and ulna. If the radius and ulna are parallel to the film and my x-ray source is perpendicular, I'm going to get a really nice view. That's like a parallel view for dental radiographs. It's accurate in size and it looks great. But if my bone is at an angle, I'm going to have some foreshortening, and the image that I catch on my x-ray will look much smaller than the bone is in reality. It's going to look shorter than it truly is. That's foreshortening. Sometimes the bone is straight up and down at the x-ray tube, and we get an end-on view. So you can have this with bones, blood vessels. I see it a lot with the intestine. So when an intestinal loop is heading straight towards the tube head, we're going to get this end-on view, and it's just a type of distortion. The body part of interest should be parallel to the film. So if we're taking an x-ray of a long bone, such as, we'll go back to the radius and ulna, the bone is supposed to be parallel to the film. When we collimate, we want to get the joint proximal and the joint distal of that bone to be sure that we have the entire bone included. So you're always supposed to get the joint above and the joint below. In general, the x-ray and film are supposed to be perpendicular to one another unless you're taking some sort of oblique or bisecting view, and that would be a situation that they might not be perpendicular. Now, this concept of magnification is also really important that you understand. The object to film distance affects magnification. When I say the term object, I mean the patient, or maybe a part of the patient, like maybe I'm talking about one femur. So the object is the animal that we're taking an x-ray of. The film is, in a traditional sense, real film. In a digital machine, it is the film sensor. And so the distance between the object and the film can lead to magnification. The further a body part gets away from the film, the more magnified it will appear. And this concept is really easy to demonstrate. Set up your flashlight in a dark room and move your fingers close to the wall and far away from the wall, and look at how the shadow gets bigger as your fingers move further away from the wall. The wall is your film. Your fingers are the object. As they are close to the wall, the image is small, and as they move away from the wall, the image is big. So this one's really easy to demonstrate at home. So on a VD image, which will be magnified more, the sternum or the spine? Hopefully you said the sternum. The sternum is further away from the film because the patient is on their back in a VD, and so the sternum will appear more magnified. What about a right lateral? Which will appear more magnified, the right femur or the left femur? Hopefully you said the left femur. When you're in right lateral, the right side is down against the table, and so the left hind leg is further away from the film and will appear more magnified. And that's what you see in this picture here. So the dog is in right lateral, and you can see that the left femur is caudal, and in the picture B, the caudal bone is bigger or more magnified compared to the femur that's more cranial. So that's an image or an example of magnification due to increased object to film distance. So taking equine limb x-rays is a little bit of a tricky subject, but you can master it. The naming of the beam is based on where the beam enters the leg and where it exits. And so there's different naming schemes for the front leg and the back leg. So in the front leg, anything above the corpus, it goes by either cranial if it's towards the head or caudal if it's towards the tail. But below the corpus, we use the terms dorsal and palmar. So that's how we name films of the front leg. If we're taking an image of the back leg, we have different terms. So above the tarsus, we use the terms cranial and caudal again. But below the tarsus, we use the terms dorsal and plantar. And then just remember that medial refers to anything towards the midline, and lateral refers to anything towards the outsides of the body. So If you're on the left, lateral is to the left. If you're on the right, lateral is out towards the right. It's towards the outside of the body. And so when we are solving these problems, I think it helps to draw the X-ray beam. So usually the straight line refers to the cassette or the film, and then the X-ray beam is going to be perpendicular to that. And so we name it as it goes in and as it comes out. Anything that's at kind of a crisscross diagonal is called an oblique, and we'll have 4 different names. But anything that's more straight, like a plus, straight across left to right, or straight front to back, those are going to have a simpler name. They're just going to have 2 pieces to the name instead of 4. So this is something that you should practice, naming your different views, and practice the abbreviations as well. Contrast studies are helpful when looking for maybe something that can't be seen on a flat X-ray. And honestly, contrast studies have been replaced by ultrasound. So in practice, we're not doing very many contrast studies anymore. But this is still a potential area for questions on the VTNE, which is why we're reviewing it. So if we are giving some form of positive contrast, it will appear radio opaque or bright on the film. And this is us adding some type of contrast. The 2 main types we have are the IVP, the intravenous pyelogram, and I have a picture of that, the upper picture on the right, or a barium study. And a barium study is often used to identify an intestinal foreign body. And the big contraindication for a barium study is any sort of perforation to the intestinal tract. We couldn't use barium in that case because then it could leak into the abdomen, and it's very irritating inside the abdomen. A negative contrast study is when we add air. So air appears radiolucent or dark on X-rays, and sometimes we would use air in order to highlight an area of interest. For example, the picture on the right is a pneumocystogram. Remember, pneumo refers to air, cysto refers to the bladder, and gram is a study. Now, sometimes there's a double contrast study, and what this means is that we're using both a positive contrast and a negative contrast together. So we could have both of those added for some sort of imaging. Fluoroscopy is real-time X-ray imaging, and this is good for dynamic processes like watching a swallow or placing a coil in the PDA of a puppy's heart. Fluoroscopy has so much radiation exposure because instead of just having 1/30th of a second exposure, this might be like 3 to 5 minutes of radiation exposure. So it's definitely high risk for the technicians using it and for the patients. Ultrasound is a wonderful modality, and there's some benefits to using it. So it's real-time imaging. We get a picture of what's going on in that exact moment. And it's great for function, especially for the heart. It's non-invasive, it's non-painful, there's no radiation, so it's totally safe for the technicians and for the patients. We can move our probe in any direction or plane. So if we're cutting a pickle, we could either cut it across or transverse on the pickle versus longitudinally. So we could either get little circle slices or we could get long oval slices, depending on which direction we cut our pickle. And it's the same thing for ultrasound. We can get different views depending on which angle we rotate our probe. We can see layers that are not visible with X-rays, and it's portable. There's all sorts of new models and technology that are out. So how does it work? The transducer, which is also called the probe, produces sound waves. The sound waves leave the transducer and then they bounce off of various densities and are reflected back to the probe. And basically, the density of the object they bounce off of sends them back at different speeds, and the piezoelectric crystal can translate that energy into a picture, basically, that we can look at. And so we see different organs have different densities, and they appear different shades of gray on ultrasound based on their density. Most machines have similar settings. The gain affects the brightness of the image. The depth can zoom in or zoom out, so you always have the ability to zoom in. If you feel like you're looking at a small cat and the bladder is minuscule, try zooming in on it. It might not be as small as you think. You might just be zoomed out too far. The transducers have certain characteristics to it, and there's a lot of choices for transducers on the market. So they all have a megahertz, and this describes the frequency of the sound waves that are leaving the transducer. The penetration is how deep they can image, and so some of our patients are itty bitty. We might have a kitten who's only, 1 kilogram, or we might have a 200-pound dog. And so we have different needs. Sometimes we need to penetrate something small, and sometimes we need our ultrasound to penetrate a much bigger abdomen. So different transducers will be used in those situations. And then these characteristics influence the resolution or the sharpness of the image. And there is an inverse relationship. Inverse means kind of opposite. So there's an inverse or opposite relationship between the frequency and the depth that it can scan. So a high frequency probe cannot scan very far. It's only for superficial structures. It doesn't have high penetration. But the clarity will be really good. The resolution will be excellent. So a low frequency probe, maybe in the range of 2.5 to 5 megahertz, has high penetration but low resolution. We are going to use this for large animals and large dog internal organs. So we can penetrate something really big, but our image is going to appear fuzzy. Medium frequency is somewhere in the range of 6 to 8 megahertz, and this will lead to moderate penetration and moderate resolution, and this is a good transducer for cats and small dogs. We're going to be able to image their abdomens, image their chest fairly well. A high frequency probe is in the range of 8 to 12 megahertz, and these are going to have really low penetration but really high resolution. So we're going to use them for superficial structures like the eye, the neck, ligaments in the extremities. We're going to get a really clear view of something that's just under the skin. It's really superficial. It's not very far away from the transducer. In addition to different megahertz characteristics, the probes can come in different styles or types. So a linear array probe has a very linear end to the transducer, and the image will appear rectangular. And these are best for superficial structures. They tend to be higher megahertz. And so the picture will appear rectangular because the sound waves bounce off of a linear probe. The next type is a curved array or convex probe. In this picture, it's called curvilinear, but these transducers have a curved surface where the X-rays bounce out, and they're used for most of our general scans. So we're going to use them for our abdomen and our chest. A phased array or a matrix transducer is used to create a 3D image, and we're not using those very often in veterinary medicine. I've seen them for pregnancy ultrasounds, and people can get a 3D image of the baby before it's born. Ultrasound machines have different modes for their operation. The first mode is called the B mode, which stands for the brightness mode, but I really think of it as just our basic mode. This is a two-dimensional image. It's most commonly used when we're scanning the abdomen. And the first picture shows a convex probe using a B mode to image the kidney. The second mode on here is called the M mode, and the M stands for motion. And this tracks the movement of something over time. And this is what we use for echocardiograms when we're looking at the contractility of the heart, or how well the chambers are dilating and contracting. And so we can see that movement over time. The time axis is demonstrated there. The third mode is called color flow Doppler, and we use this on top of B mode to see the flow of blood within a vessel. And so we can tell that blood is going one direction in an artery and going the other direction in a vein, and they show up as two different colors. This is really useful if we're looking to see if there's blood flow to the spleen when we suspect a splenic torsion. We can look for this color flow Doppler and blood flow in and out of the spleen. We can also use color flow Doppler if we're trying to find the adrenal glands and we found a structure, it's nestled right in between a bunch of vessels, and we're trying to decide, is that the adrenal, which should not have flow inside of it, or is that a blood vessel, which would have flow? So those are uses for color flow Doppler. Ultrasound has its own set of terminology, which is different than X-rays, and so we describe the appearance of something as its echogenicity, that's its brightness, and it's always in comparison to the tissues around it. So if something is hyperechoic, it is brighter or more white compared to the tissues around it. If something is hypoechoic, it's gray, but it's a darker gray compared to the tissues around it. If something is isoechoic, it is the same echogenicity, it is the same shade of gray compared to the tissues around it. And if something is anechoic, that is the absence of any sound wave or echo off a structure, it shows up as black. So the absence of any sort of echo is anechoic. And if you were to describe the urine in a bladder, it would be anechoic because it's just black. So echogenicity is another language that you need to be aware of. And so that's it for today. I hope this was helpful in reviewing diagnostic imaging. It's definitely a tricky domain on the VTNE, and I think it's important to practice different types of problems about these concepts so you can see how it might be applied and what sort of information you need to really know and be able to apply. Good luck, you got this.